So I'm going to start off, and a big thank you to the MatCHNet team for inviting us. So Kate Lewis and I are part of the team that developed the ECHILD database, which links education, hospital data and social care data for all children in England. So if you go to the next slide, please. So the aim of this short seminar is to demonstrate the scale and value of ECHILD for studying rare diseases. So Kate's going to be presenting her work on children with major congenital malformations. But before I hand over to Kate, I want to make 2 points, and we can come back to this in the question session. Firstly, although ECHILD, we feel ECHILD is a great achievement, we are playing catch up with Wales and Scotland, where these data sets have been usable for some time and they have deeper, richer data already linked in. But from a policy perspective, we now have the opportunity for comparative studies between England, Wales and Scotland using these linked data. And the second point is that ECHILD will be available to applicants from the UK later this year, sometime in autumn. So some of you may well be interested in using it. All right, over to Kate. Thank you.
Thanks, Ruth. So I'm going to talk through a descriptive study that uses ECHILD, and this is variation in recorded special educational needs amongst children with major congenital anomalies born in England. And that's quite a mouthful, so I'm just going to break down some of the key phrases here. So firstly, major congenital anomalies are abnormalities of structure or function that are of prenatal origin, that have significant medical, social or cosmetic consequences for the affected individual, and they typically require medical intervention. And some of the most common in England are listed on this page. So individually, major congenital anomalies are quite rare, but they're thought to affect about 2% of births according to registry data. And thankfully, nowadays, about 95% of children with major congenital anomalies survive through to school age. And this is thanks to improvements in paediatric surgery over the last few decades. So they're more likely to go to school and require additional support with learning, which is where special educational needs provision comes in. So this is any educational provision that's addition to or different from that given to children or young people of the same age. And there's some examples listed on the page there. And I just want to note that I use the term recorded special educational needs in this presentation. And this really is to reflect the fact that we are using an administrative data set. And although we have an indicator of SEND provision, we don't actually know the quality or the components of that provision that they're given. So why do we want to look at this? Well, obviously for families that have children with particularly rare conditions, they want to know prognostic information, and for clinicians too. Work like this could be used in service planning. If we know a certain amount of children are born with a condition, then planning for the future becomes easier. Also, by looking amongst children with the same specific conditions, we can be more confident in untangling the sources of variation in SEND provision, whether that be across the country, over time, or following a major policy. So that's where I come on to my second part. So when I talk about the government reforms, I'm talking about the Children and Families Act of 2014 and the subsequent Code of Practice. And at the time, this was hailed as one of the most significant changes to special educational needs and disability policy in England for 30 years. And some key points from it, it was hoped to improve co-production, cross-organisation working, there was changes to funding, and also the local authorities were supposed to set out a local offer of different support available. Also, as part of this change, the categories of recorded SEND changed. So what had been School Action or School Action Plus changed to SEND support. And this is arranged by the school and includes additional support, particularly in the classroom. And what had been statements of SEND got changed to Education, Health and Care Plans, or EHCPs. And these are arranged by local authorities for children whose needs cannot be met by SEND support. In the study, we also split mainstream schools from specialist school attendance, simply because we know that the type of support that children will get in specialist schools is going to differ, such as smaller classrooms. So this is mainly special schools, but also includes alternative provision. So 2 objectives, firstly, to estimate the prevalence of recorded SEN in primary school. And we start at year 1 because that's the first year that of compulsory education when children are 5 or 6. And we also are estimating the change in the prevalence of recorded SEN in year 1 for children who go into year 1 prior to and after the 2014 reforms. So the linked data sets used in this study, I think a lot of you will be interested in this. So in ECHILD, we have hospital episode statistics, and as part of that, we have admitted patient care. So that's hospital admissions, and this includes approximately 97% of births that happen in England too. So in this cohort, we used births from 2003 to 2013. This is further linked to ONS mortality records, and together between 0 to age 1, we use a code list defined by Eurocat and others to define whether a child has a major congenital anomaly. This in turn is linked to the National Pupil Database, and that gives us information on children that attend state-funded schools, and our follow-up is until the end of the school year 2019, which is the last school year before the coronavirus pandemic. Further, this is linked to get information about schools data. So this is an open source data provided by Department for Education. It gives us additional information on things like school type. And as you'll see, the ages down the bottom, we follow up children in primary school from year 1 to year 6. So altogether, we have a final cohort of about 5.2 million singleton children. And in our cohort, we identify about 3.5% of children having any major congenital anomaly. So some results. So the first objective was about variation recorded SEN by major congenital anomaly. And this simple chart shows the prevalence of children, firstly without a major congenital anomaly that have any recorded SEN in primary school. So you'll see that children without a major congenital anomaly have about 24% prevalence, whereas approximately 42% of children with have. So there's a higher rate there amongst children with any major congenital anomaly. And the colours show the different categories that I've explained. And you can really see that this difference between the 2 groups is driven by support at the highest level. So this is the same chart again. It's just a bit more confusing because there's so many groups on it, but you'll see there's the no major congenital anomaly and any major congenital anomaly up here, just to get an idea of the prevalence in the overall population. So down the bottom here, we've got 12 system-specific subgroups of anomalies, and within them we have specific conditions. And in this data set, we were able to look at 25 individual conditions and within 12 system-specific subgroups. So there's a lot going on in this chart, but I wanted to point out some key findings. So firstly, children with nervous system eye anomalies and chromosomal anomalies have the highest prevalence of recorded SEN, with children with chromosomal anomalies having almost all of them having some form of recorded SEN. Again, you can see this is really driven by SEN support at the highest levels. I also wanted to show you isolated versus average in each group. So children with isolated anomalies, that means they have an anomaly just in that subgroup compared to the average. And as you might expect, children with an isolated anomaly, meaning they probably have a less severe condition, are less likely to have SEN recorded. So our second objective is difference in the prevalence by the policy period. So this chart shows the absolute difference with 99% confidence intervals between children who went to year 1 after the policy period versus before. And anything above 0 is an increase over time, and anything below is a decrease. And really, you can see here that following the policy period, there was about 4.2% decrease amongst children with no major congenital anomaly, and this was actually higher amongst children with any major congenital anomaly. And I've just included the any and isolated groups for each subgroup. And you can really see this is across the board, this reduction in SEN provision, apart from a few individual groups, such as EFNN, which means ear, face, and neck. So this chart shows SEN support overall, but what we really want to look at is the subgroups to really understand the underlying impact of these changes over time. So this is the same chart, but just for specialist school attendance. And you can see there's much less variation or change over time, apart from children with nervous system anomalies. Similar patterns can be seen for EHCPs in mainstream school. But when you put in SEND support in mainstream schools, so the lower level of support, you can really see that's where the differences are coming into play. And this is particularly for children with conditions that are in these middle anomaly groups. And as you remember from the previous chart, these are children that are less likely to have SEND support compared to other groups in the first place. So some key findings and implications. So we find that 2 in 5 children with major congenital anomalies have recorded SEN, about 1.7 times greater than those unaffected peers. After the SEN reforms, there's about 1 in 20 fewer children with major congenital anomalies that have recorded SEN after the 2014 reforms. And this really fits in with the experiences of children, their families and teachers, as indicated in qualitative and PPI work. Really, these changes in SEN provision seem to reflect rising unmet need. So I think we've been able to show today that there's real potential for ECHILD to be used, particularly if this was used for routine planning and monitoring SEN provision. For children with major congenital anomalies, it's important that more code lists are validated so that we can be 100% sure that we are looking at the right groups. So some future research. So as part of the HOPE study, we're examining a wider group of children that potentially have a need for SEN provision according to health data. And this is important because although children with a major congenital anomaly have a higher prevalence of SEN provision, they only make up about 5.5% of the total population. So there's a lot of other children without major congenital anomalies that receive SEN. So we really want to look at this question about whether SEN provision is equitable. And of course, here we've just looked at a descriptive study of quantity. We're also going to look across local authorities and schools. But we really want to also look at the quality of that SEN provision. And that's why as part of the HOPE study, there's a team in Cambridge that have been doing lots of qualitative research. Thirdly, we're looking at the long-term outcomes of SEN provision. So receiving SEN provision or not, does that make a difference to the health or education of these individual children? And we recommend you come along to the MatCHNet workshop, which is next Thursday week, by our colleague Bianca Di Stavolo. She'll be talking through a specific method that we use in these studies. So some acknowledgements. Specifically want to thank Maria, who started off this work, and just to say that these results are subject to final checks and peer reviews. And for ECHILD updates, we can talk about it in a second when I stop sharing, but we recommend you follow the Twitter account that's listed there, or join the ADR UK mailing list that's also there too.